Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Angie Franks, CEO of Central Logic. Welcome, Angie, and thank you for joining us.
Thanks, David. It's a pleasure to be here.
So, Angie, I'd like to start off by asking you to take a few moments to describe to us what Central Logic is, what it does, and how you ended up as the CEO of Central Logic.
Sure, absolutely. I have the pleasure of leading this phenomenal company that helps health systems solve the problem of access and orchestration to healthcare, making sure that patients are in the optimal location, the optimal setting for the care that they need at the time that they need it. And the company was founded really first and foremost to solve the problem of acute interfacility patient transfers. So these are patients that are really sick. They are in a setting. They might be in a community hospital or a small rural hospital, and or they could be in an urban setting where that facility does not have the capabilities to take care of that patient. They might not have the specialty available or that service line available. It might be that the patient requires a certain type of procedure and requires equipment or technology. It could be that it just exceeds the acuity level of a particular facility, or maybe they don't have capacity. Helping to facilitate that patient transfer and getting the patient to a setting where they can be treated efficiently and effectively is the problem that we were founded to solve more than 10 years ago. And since that time, we have expanded our orchestration capabilities from patient transfers into the health system to patient transitions out of the system to post-acute and step-down facilities or rehab, or even transfer to the home where a patient is going to continue to receive services in their home environment. And then, including all of the logistics and facilitating the transportation and getting the patient moved from point A to point B. So we solve a very particular an acute problem for health systems. And I found myself with this opportunity to lead this company after serving on the board of directors for a number of years and stepping in 2017 when the board had made the decision to really drive the company in a new direction. And I stepped in to lead it. So it's a wonderful problem that we solve, and one that impacts patient lives first and foremost. When you can compress that time and get the patient to the optimal setting of care, and you can do that efficiently, and you can take what might have been a 2 or 3 hour process, and you can take that down to minutes, patient lives are in the balance, and they are impacted, and the clinical outcomes for those patients are impacted positively. And so that is the most important value that we bring to the healthcare system. Beyond that, it has a revenue impact, it has an operational efficiency impact, and culturally, when we come in and help solve this problem, it culturally starts to change the health systems that we work with, because they truly begin to operate as one system of care.
Sure, and that's critical. I mean, I've had many experiences over the years, both myself as a patient and with family members, having sort of miserable transfer and discharge experiences. And it sometimes takes that sort of experience to be able to see the need for a change and then to motivate change. Mm-hmm. And I think over the time that you've been in your current role, I would expect that you've seen growth in risk-based contracting for the health system as a whole that might be a customer of yours, where the need to manage transfers effectively becomes, as you said, a financial issue as well as a care management issue. Is one side of the equation more of a driver these days than the other, or is it really sort of part of the same package?
Well, it's just such a great question, and you are exactly correct. The reimbursements and the economics for hospital systems has been undergoing a shift from fee for service to more risk-based contracting. And while we've been on what I would consider maybe on a national basis, I would consider that pace of change somewhat slow. There's pockets of and places in the country where maybe we've accelerated that a bit, but the COVID pandemic, is certainly putting that in high gear, and we're going to see an even more rapid acceleration, I believe, in the future to more risk-based contracting. And when you look at this problem of orchestration of access to care and ensuring that patients are in the optimal setting, the value proposition is as important in a fee-for-service environment as it is in a risk-based environment. The risk-based scenario, so as we shift to more value-based care, health systems want and need controls in place to help ensure that their patients are in the optimal setting, and they want to and need to be very involved in that decision-making process. And in a world where our choices for where we get care is so distributed, we're not in the days of risk-based contracting and managed care of the early 90s, where the primary care physician was the focal point and the go-to point for every decision as to where the patient was going to go. Today, it's a much more distributed environment. So to help facilitate that decision-making and help really have a centralized function inside of a health system that supports all of their providers and their patients, that is where the controls inside of an access center really come to play, and that's what we provide. When you're talking about fee-for-service revenue, supporting service line growth strategies has been a key revenue driver for health systems as they work to shore up gaps in service lines or bring in new physicians and specialty groups to drive new capabilities inside of their health system. The technology and the solution that we provide really helps to make that service line thrive and make it easy for other facilities and other providers to send patients and refer those acute patients into the health system. So in both worlds, whether it's a fee-for-service, patient transfers, service line revenue, growth strategy, or the mix of revenue is shifting to more value-based care, you need to optimize both. You need to optimize the revenue, make it easy, get patients in, make it easy to refer patients to you. And on the control side, you also need that support to help ensure that those patients are going to the places that are optimal for their condition, and that might be in a risk-based contract inside of your referral network.
Right, sure. And I mean, as they say, the future is here, but it's not evenly distributed. And certainly there are the pockets or more than pockets of fee-for-service reimbursement that persist, but there's growing risk-based arrangements and more quote-unquote closed networks of care providers that work on these sorts of issues together. Are there broader reasons for integrated delivery systems to try to work better together as integrated delivery systems? I mean, it's in the name, right? Integration. But a lot of them don't necessarily act that way. They've sort of grown over time by accretion, by consolidation, by acquisition. Do you see in your work opportunities for organizations like that? And would you put different sorts of organizations on a curve, if you will? Is it entirely based on how far out are they from that merger or acquisition? Or are there other factors at play that you see affecting better integration?
Right. Yeah, no, it's a great question. We've had that term integrated delivery networks and integrated delivery systems for I think decades now. I know that was the big term even back in the early 90s with managed care, and it persists today. But the reality has been hospital systems have often operated more like collections of facilities, collections of hospitals and collections of other care settings. And one of the things that we've heard from leaders over the past few years is this drive to systemness, this intense focus on how do we actually, as a multi-entity health system, start to operate like an integrated system of care. And that is one of the really key problems that CentralLogic helps our clients address, and that is starting to operate as a system, leveraging all of the resources of their health system, all of the capacity. The capacity could be beds, it can be other resources inside their system. Leverage their staff and their providers and the specialists, and ensure that the demand that's coming into their health system for their services is aligned, and those patients are appropriately placed in the optimal setting of care for the services that they need. And, I'm going to give you a couple examples here. So I'll give you kind of.
That's great. I was going to ask, can we pull this down from the 30,000 foot level to some real concrete examples? Because this all sounds great. And the next question is, what does this actually mean in the real world?
Well, it's such a great question, because I've been in healthcare for 30 years, and when I got to start working with CentralLogic, I realized, 25 years in healthcare, I had no idea that it just wasn't intuitive to me to think about how does a patient really get into a bed inside of a hospital system? Like, how does that actually happen? I guess intuitively I thought, well, I guess it's through the emergency department. And yes, there are some percentage, probably in the 15 to 20% of all inpatient stays are coming through the emergency department. And then there's some percentage of inpatient stays that are coming through scheduled surgical procedures where the patient needs a room and they'll be staying for an extended stay post surgery. But the rest of the patients that are in an inpatient setting, the front door for the health system is really patients being transferred or moved in from other settings of care. And to make that process happen, it is very complicated. When a critical access hospital has a patient that is having a cardiac event, or they have a problem that is maybe, let's say, cardiac related, and they need to be moved out of that critical access facility to a setting that can deal with that cardiac event. The physician is picking up the phone and making a call and calling hospitals to see who can take that patient. And the decision to say, yes, we can take that patient, or no, we can't, has many factors involved to be able to just make the decision. Factors from, is there a specialist, is there a physician that will say, yes, the patient is medically stable and ready to be transferred? A phone call and a consult needs to happen to make that, to get that decision. And if the doc says yes, then it's, well, do we have a bed inside our facility appropriate for that patient? And if so, at which location? And then it's, and how are we going to get the patient there? How are we transporting them via ambulance? Do we need to order that transport? All of these factors come together, and health systems that haven't created a function to take these calls and have the technology pulling from the many systems that provide the data to be able to answer those questions and say, yes, we can take that patient. If you haven't made that investment, what's happening is people are calling your health system. They're getting bounced around with, I'll let me look up and see if I can find a doctor who will take this call. Then it's, let me see if I can find a bed. Let me see if we have the right staff. Let me see what facility. And now you're into hours of time, lots of phone calls back and forth, just a ton of friction to be able to say yes, because an individual doesn't have all that data pulled together to be able to answer that question.
Right. And a patient and the care team doesn't have the time at that moment.
Exactly. They're just sitting there waiting in the room. They're waiting to find out. The family's wondering what's going on, and they don't have time. These are time sensitive.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Angie Franks, CEO of Central Logic. Angie, we're talking about the desperate need for better information and better connections when transfers are needed. And this is heightened for me, for everybody in the time of COVID, when I see, for example, on social media, reports of somebody saying, my mom needs a bed. This is her particular situation, and she needs a bed within an X mile drive of such and such hospital. And when you're relying on Twitter and Facebook and your personal network to find a doc who will take your mom, we're in a bad situation. So I understand where you're going with this and sort of the technology that you're offering that can short circuit that kind of crazy approach and rationalize it. And I imagine you're seeing the need for that not only in the current situation, but over time in more normal days as well.
Yeah, absolutely. And the technology serves to really facilitate a different way of operating, a different way of running your health system as one system of care to make sure that you're looking across your entire health system to find the optimal resource for when that call comes in that says my mom or this patient needs a bed. So while the technology can pull all that data together from many different systems, it's not just coming from one, medical record system. It's coming from multiple systems. The technology enables that, but it's all the workflow and the process flow and the change that has to happen to drive that systemness, the incentives that need to be put in place to align, the leadership across that health system to operate too, like a system of care. And the benefits are not just to the patient, that they get to the room, they get to the setting, they get to the care that they need in the shortest amount of time for the ideal clinical outcome. It's also operationally much easier we take out hundreds of workflow processes and replace that with a handful. It is strategic, the data that comes out of who's calling for what needs and where are we placing patients and what are the gaps in care that we have, how do we coordinate that for patients coming in and patients coming out so that we don't have patients occupying the highest acuity bed as their condition changes and they can be moved to maybe a setting outside of the walls of the hospital, maybe to home, maybe to rehab or some sort of skilled nursing facility, and you free that bed up for the next patient that needs it on an inpatient, on an inpatient basis. But
Sure.
this whole metaphor of a system of care has never been more true than what's happened with COVID, where we now have regions, geographic regions, multiple health systems coming together. For example, in the state of Arizona, with the Arizona Surge Line, the entire state is operating as a system of care to manage the surge in demand initially for COVID, and now COVID plus the impending, flu season that's really upon us, that will put more stress and pressure on the limited resources and capacity available. That too is a system of care.
Right. So as you see that working in the context of COVID, I imagine that sort of works differently for different organizations in different places. And maybe for some, this is not something that they are dealing with if they don't already have it in place or can't think about implementing a new system right now. How do you see the uses of your systems in this time of COVID, and sort of how do you see the value of the toolkit being recognized or changing or expanding in, as we come out the other side?
Yeah, I think COVID has just been such a tremendous catalyst for the healthcare industry to really look at what happened when we put that much pressure, demand pressure and surge on our system, what was the fallout from that, and how does that inform us about where we need to make changes and be better prepared moving forward? And so, I think that COVID has just illuminated some of those issues, and now collectively, as a participant in our healthcare system, it's up to all of us, providers, payers, technology companies, employers, all of us to come together, governments, state and federal, and say, how do we work on the different things that we've learned through this pandemic to operate more effectively? One area that you touched on earlier, David, was the shift to value-based care. I think we absolutely will see growing and more rapid movement towards risk-based contracting as we come out of this pandemic. The use of technologies like telemedicine, you saw the walls just come down, the barriers for utilizing telemedicine in our healthcare delivery system for acute and non-acute services. It just overnight transformed. We aligned the economic incentives. There was a business imperative for hospitals. Patients absolutely love it. And what are we doing? We're keeping patients in the optimal setting of care for their needs at that time. So we're not going to go back from that. We're going to go forward and figure out how to optimize these technologies. Maybe we built some of this stuff really quickly in the midst of a pandemic, and now we've got to step back and say, how do we really make this work optimally in our overall care delivery model? But I believe that's going to be, this pandemic will forever change the way we care for people and the places and the settings in which we care for them. And I think those are positive outcomes.
Right. So I know you've examined, or folks have examined, the outcomes or the outputs of the uses of your systems. And I wonder if you could speak to some of that. Again, sort of how does this work in the real world? How have people, analyzed and looked at the uses of your systems, and what does this actually do for the healthcare provider community?
Yeah, well, you've probably heard a gazillion times people use the phrase "no margin, no mission," and
Right.
and the reality is, I mean, it's just such a true statement. These health systems are mainly nonprofit. There are very large for-profit health systems, and 4 of the top 5 for-profit health systems are CentralLogic clients, and that's not by accident. But we serve the nonprofit health systems equally, and it's equally important because every net new patient transferred into their system has a contribution margin, meaning after all the expenses, there's a tremendous impact to the bottom line, and that impact on a blended basis is just under $11,000 per patient. And so when you look at, as a health system, that decision to say, how can we do this, run this process more effectively? How can we make it really easy for other facilities and other providers to send patients to us? What we do is we help them make that really easy. We help them leverage all of the resources of their health system and operate as a system of care. And the contribution margin and the financial impact is a tremendous ROI, where these initiatives pay for themselves. Typically, our contracts are paid for. The first year of the contract is paid within months of go live. And, we have case studies and real examples of large multi-entity health systems and the ROI that they track. It's really, I think you have to be able to demonstrate an ROI to do business with health systems. And this is a very predictable and forecastable impact, because when you make it easy for somebody to send you patients, you're the first phone call every time. Because for health systems that have not invested in this or are using their electronic medical records or a homegrown system, it's difficult to get to the answer yes. And he who makes it easy gets the calls, and it's very predictable. So the ROI is economic. That the dollars that I just described really come straight from a study that that was done at the University of Utah, where they really peeled back the contribution margin on patient transfers, and they broke it out geographically, and they broke it out by specialty, and it's a tangible impact on a hospital's business and their margin and bottom line. And with that, they can serve a lot more patients and expand their reach and add more service lines and better serve all of the constituents in their communities. And I think that issue has never been more important than it is today.
Right, it's critical, as you said. No margin, no mission, and to the point we were talking about a few minutes ago, no margin, no mission also means no margin, no resources available in a pandemic, and broad conversations that are happening about what is the standby capacity that we need. Do we need more? Do we need less? But without this sort of thinking, there won't be any.
Exactly.
Angie, to wrap things up, I want to ask you my final question, which is, if you were to wake up tomorrow and find yourself 5 years in the future, what's one thing in healthcare that you would hope or expect to find has changed dramatically?
I really hope 5 years in the future, we have truly aligned the economic incentives with the best patient outcome. That we have really made significant progress on a shift to value-based care and population health management, and put the incentives and the focus on what all of the underlying prevention and aligning those economic incentives to the prevention and health and wellness to keep people healthy and out of the hospital. That is my hope.
That would be nice. Thank you very much for joining me.
You bet, David. Thanks for having us.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.